So we have a setup here with a actual biological model, and I'm able to start by the normal examination, which uses an endoscope, and it's hooked up to the Stryker ENT Navigation System, which allows me to co-localize using a pre-recorded CT on the same screen as the endoscope, the vision from the endoscope that I'm getting. So I'm looking at a middle turbinate on the right side, and what I'm going to do is take a moment to walk us through some of the steps of a hybrid FESS or sinus surgery using some traditional techniques as well as a balloon as an adjunct, and also how we integrate the navigation with that. So first off, I have a set of interfaces with the instruments that we use for the navigation. First off is a precision pointer, and the precision pointer allows me to localize externally, but of course internally with really high accuracy. The inferior turbinate, the middle turbinate, the rostrum of the sphenoid, and if you're following along on the CT, you'll see a really nice ability to precisely point and also delicately manipulate with this pointer. It can also be bent, it's malleable, so this is a distinct advantage with some of the other technology that's out there. I can point it in whatever direction towards whichever sinus I want. Then I have interfaces in the form of clamps which can be added to whatever instrument I care to work with. So in this case I have a curved suction, and the wire is not integrated to this. So I can take any suction out of my regular FESS tray and I can clamp this on here, and now I can track with it. It's a simple matter of registering with the receiver, and I can similarly navigate with the tip of that instrument. And furthermore, we have our balloon technology. So this is the Express multi-sinus dilation device, and this is fitted with a wire, a navigation wire through the center of it, and that allows me to navigate the tip of this instrument directly on the same screen. So there's no transillumination necessary with this technology. So the first thing I want to do, I may typically perform a ethmoidectomy if there's ethmoid disease, but oftentimes I'm concerned with frontal or maxillary disease, and that's where an instrument like this really comes in handy. So as you can see on the endoscope, the tip of this instrument has been bent at a 70-degree angle, and there's a pre-bending process that occurs that allows us to bend to all of the preset angles for each of the sinuses we might be treated. So in this case, I'm going to proceed with dilating a frontal sinus, and I'm going in the usual place. I'm trying medially against the middle turbinate. I'm seeing some resistance, so I'm going to go behind the uncinate process here. I'm going to angle a little more laterally, and look, now I have a 2-centimeter advancement into the frontal recess, and I'm confirming that on the CT scan on the sagittal view. And so now I can advance my balloon with that confidence of localization. I'm going to ask my trusted assistant to inflate the balloon. I will inflate that for a few seconds. We get some crackling sensation and a feeling that the balloon now is ready to deflate. And we can see very nice pathway. This is a 0-degree scope, by the way, and even then I'm seeing a very nice pathway up into the frontal sinus. Now what I'm going to ask my assistant to do is rebend this in a maxillary configuration. And again, we're using scopes that are a little smaller diameter, which in my practice is preferable. Now the technology allows us to have just as good of a visualization with a smaller bore scope, and that creates more room for the instruments. Now here we have a patient with previously unoperated, but they have a small false antrostomy here, or false ostium, and I'm pointing to it with the tip of my instrument. Now that's not what I want to dilate, actually. The part I want to dilate is the natural ostium, which is actually on the other side of this part of the uncinate process where I'm touching with the tip. So that's the uncinate process. And so the target is right about there where the tip of my instrument is. But you can't see it directly, so that's why we have this bend, and it's a nice bend of about 115 degrees. We're going to slip around, and we can see with my navigation now, the tip on it, if I'm looking at the coronal view, I can see that the tip of the navigation pointer is just inside the lumen of the maxillary sinus. It's exactly where I want to be. So I'm going to advance the balloon over top of that probe, and I'm going to ask my assistant to inflate. And you see that instant medialization of the uncinate process. And let's deflate, please. And so now I can withdraw my instrument and the balloon, and I take it out. So I haven't been misled by that false ostium, but I know that I have targeted the correct spot because of the interface with the navigation system. And if I so chose, I could take my precision pointer, I could bend it at a pretty acute angle. I can come in to confirm that as well if I wanted to. And I can see on the coronal view that I'm actually inside the lumen now. I'm advanced further than I was able to before, thanks to the dilation I've just done. And then we'll assume that this patient also has sphenoid disease, and so sphenoidotomy is easily accomplished with this technology. So we've rebent, we've refashioned the tip of the express device using the dilation by the bending tool, and that allows me to go for a different trajectory. So now I'm going to go medial to the middle turbinate, and I'm actually able to see the ostium of the sphenoid sinus. And I'm navigating right to it. Now, there are cases where it won't be obvious, especially if there is true disease. The edema that surrounds the sphenoid ostium may occlude this actual hole, and so you're not going to have that to rely on. So you need to have the navigation, which we do in this case. So that allows me to actually advance a little bit into the lumen, and you can see on the axial view now that I'm in the correct place. And I can advance my balloon, and I'll ask for the inflation. And please deflate. And after I've done that, I can withdraw it, and you see the full diameter. So we've gone from about 2 millimeters to probably a 6 meter dilation. And there we have the sella and the lumen of the sphenoid. And very nicely done, atraumatic. You see the superior turbinate adjacent to it and the middle turbinate. Now at this point, I could proceed with an ethmoidectomy with my traditional instruments. I could use my clamps or shavers to remove the ethmoid tissue and complete a FESS. And I really like this setup. There are obviously choices that we have in the instruments we use. This particular device, the Express, it's really the most analogous to the instruments that we're trained to use, that we're comfortable using for FESS, such as, well, rigid probes and seekers. I can manipulate, as you saw, manipulating the middle turbinate, applying gentle pressure or traction to the tissue that I'm on the edges of the tract I'm trying to create. And that's very valuable and really intuitive.